Good afternoon and welcome to the City Club of Cleveland. My name is Mark Rosenberger. I am Director of Production and Special Projects at IdeaStream. I am very pleased to introduce today's program, Body and Pain. For the past week, IdeaStream has embarked on a multimedia examination of pain, the most common reason people go to the doctor. Chronic pain affects at least 116 million American adults and costs the nation up to $635 billion in medical treatment and lost productivity. Besides the physical agony of pain, it takes an emotional and mental toll on patients and their families. Our panelists will help shed light on chronic pain. Dr. Jeffery Janata is an associate professor for the Department of Psychiatry and director of the Behavioral Medicine program at the Case Western Reserve University School of Medicine and the University Hospitals. Dr. Salim Hayak is associate professor for the Department of Anesthesiology at the Case Western Reserve University School of Medicine and chief of UH's Division of Pain Medicine. And Dr. Catherine Koppelman is clinical assistant professor at the Case Western Reserve University Francis Payne Bolton School of Nursing and chief nursing officer at University Hospitals. Despite decades of research, doctors have few tools to measure pain objectively, and treating pain remains a significant challenge. Pain is a self-reported, often invisible problem. Furthermore, pain is difficult to treat because everyone experiences it differently, and it can even exist without an apparent underlying cause. Besides the physical agony of pain, it takes an emotional and mental toll on patients and their families, and for some, that leads to addiction and fraud. Moderating today is my colleague at IdeaStream, Mike McIntyre, who is host of The Sound of Ideas, which is heard on 90.3 WCPN. He is also a columnist for The Plain Dealer and pens two columns, Tip Off and Laugh Tracks. IdeaStream has had many partners in this endeavor, The Plain Dealer, Net Wellness, WKYC Channel 3 News, and of course the City Club of Cleveland. And now, Mike McIntyre.
Thank you. Thank you very much, Mark. And thank you as well. And I want to welcome you to this, what we call over at IdeaStream, a series of packages of stories about things that afflict Mark Rosenberger. We've had heart disease, we've had diabetes, we've had lack of sleep, and I had no idea you were in such pain. But today we will talk about pain, and it's good to sort of start with the idea that we can laugh a little bit about it. Not a laughing matter for people that are suffering from pain. And we experienced this just the other day, Dr. Janata, when we were talking on our Sound of Ideas show. So many people called in and really expressed the kind of feeling and the kind of pain that's further than just the physical pain that this causes. So let's start and talk, if we could, Dr. Janata, about a definition of pain. What exactly is pain? Mark mentioned at the beginning, you really don't have a special pain meter to tell how much somebody is hurting. It's something they tell you. Can you put a finger on it?
Well, it's a subjective experience, and so we rely on people's self-report of their pain. But it's defined as an unpleasant sensory and emotional experience that's described in terms of tissue damage. And that captures just what you're describing, not only the sensory nature of pain, but the emotional aspects of pain as well, and the suffering that is so much a part of pain that some of the callers were in fact expressing. And
two different kinds of pain we've learned, and Dr. Hayak, can you go through that with us? There's acute pain and there's chronic pain. What's the difference?
Correct. You could look at pain in different ways. One of the ways to divide them is based on time. And so acute pain is the pain that you would experience following an ankle sprain or a fracture or an operation, and it's usually supposed to heal. And chronic pain is the pain that would last beyond the expected duration of an injury or a damage, or one that you live with every day due to chronic inflammation or to nerve damage generally.
Catherine Koppelman, is the distinction between acute and chronic pain well understood, do you believe, amongst the general public?
I think it is, in the sense that when something comes on suddenly and there's a specific reason for it, like surgery, or if one had an injury, that's the acute pain. I think what's misunderstood is how acute pain can, over time, become chronic pain, and how that becomes really an illness for an individual.
So you walk into the sliding glass door, which happens to be closed, not knowing that it was closed. Mm-hmm. That pain is acute pain. Mm-hmm. The more extended pain, the back pain that people talk about, is that always a structural pain? Is it something that you did when you did walk into that door and you experienced that pain 10 years out? Is it still a structural problem, or is that pain coming from somewhere else? Is it an impulse? We talk about how the brain can control some of these things. Dr. Hayak, is it still a structural problem?
Well, back pain is a wastebasket diagnosis, if you want, because you could have a lot of things causing back pain. You could have structural problems, and there are a lot of structures in the back that can cause back pain. And after a while, like Kathy said, if you've had the pain for a long period of time, you have a memory for the pain in your nervous system, whether it's in the spinal cord or higher up centers, and you would have what's called central sensitization. So it's a complex issue, but having a chronic back pain is much better diagnosis than having cancer-related pain or a terminal condition which is associated with pain. So while patients really are suffering and having discomfort, it's not the end-of-life condition.
Mark, your back is okay?
Fine, thank you.
Okay, thank you. Can you add a little bit more to that, doctor, about the acute versus chronic and where the pain is really coming from in a chronic situation?
Well, we've got to be careful about really coming from. It sounds a little bit like we're trying to distinguish between pain that's real and pain that's not, and that's an artificial distinction. But we do know that, as Dr. Hyatt suggests, that that the brain in its plasticity will learn pain in the same way that it learns any set of connections. And over time, even without a nociceptive source, even without a sensory input, the brain will continue to experience pain.
So if somebody says it's all in your head, that may really be true, but not in the sense that we
not in
might
the sense
mean it.
you normally mean it. Yeah, that's exactly right. And it is essentially a habit. And that's when chronic pain then takes on a life of its own. And that pain may or may not be related to the injury or the source or the mechanical source of structural pain that first got it started.
Catherine, then what is the frustration for healthcare providers then when the only way to treat something is for somebody to tell you what it is? And it's difficult for some of us to put that into quantifiable terms. You see the chart with the smile on one side and the frowny face on the other, and you want me to put it between 1 to 10. And I'm not really sure what a 10 is. Never been hit by a train, but I'm figuring that's the 10. 1 is stub your toe, and I'm like, I don't know, maybe it's a 4. But for me, a 4 might be someone else's 8 and someone else's 6. So how do you really understand exactly what it is you're dealing with that you're trying to treat?
Well, it's exactly as you describe. It's your own subjective experience in how you express your pain. And I think that what causes frustration is that if it doesn't fit into the method that we have developed, it's taking the time to really connect with the patient, to understand the patient's experience and how they express their pain. Some people are raised in cultures where they're very stoic. So for me, I may be experiencing a lot of pain, but I'm not going to express it. Whereas others will express it in ways that don't match with what they're doing. And so you have to be very careful, I think, as a clinician, to put aside your biases of what you see and not judge, and really go with how the patient expresses it.
And everyone does express it differently. A recent study by Stanford talked about the difference between men and women. Can you talk a little bit about that study? Whichever one wants to take that, the most familiar. Dr. Janata?
Well, this was a study that looked at ratings of pain. Again, we're talking about that 0 to 10 scale. Ratings of pain by men and women, and found that women tended to rate their pain more frequently at higher levels than men did. And it sort of flies in the face of the cliche, the sort of commonly held assumption that women actually have higher pain tolerance than men do.
There's a whole bunch of I told you so's at the breakfast tables after that study.
But the problem with the study, the problems are several, and really the issue is we don't know what the difference actually is. Is it that women understand the 0 to 10 scale or interpret it differently than men do? Is it that they're truly experiencing pain differently? Are the emotional centers in the brain lighting up more than the sensory centers are, and so the response type is different? it opens up as many questions as it answers.
So you don't look at statistics like that when someone comes into an office. It's not about what gender they are or that type of thing. It's getting to know that person personally, as Catherine said, to know how it is they express their particular pain.
And how they describe it, the terms they use. Typically pain is described by people in sensory terms. Pain is crushing or stabbing or burning pain. But they also can describe it in emotional terms. It's intolerable. It's the language of suffering. And that's when you begin to take a look at both of those components, that both the sensory and the emotional components that always accompany pain.
There was a recent report by the Institute of Medicine, and it said, quote, given the burden of pain in human lives, dollars, and social consequences, relieving pain should be a national priority. Is it not a national priority, Dr. Hayak?
I think people have access to physicians and to pain treatments. The problem with chronic pain is that it impacts function. And where we have not done so well is, while we are able to control pain, a lot of times we have not been able to restore function in a lot of those individuals. And that's where a lot of the dollar figures come in. And it is much more difficult to restore function than it is to restore pain, to control pain. And it should be a national priority, I think, but I think we're far off from restoring function. We may be able to control pain in a lot of the individuals, given proper referral.
I don't know that I would totally agree that it's a priority, because if you just look at the reimbursement really does not reward clinicians to have the time to really connect with patients, do the kinds of assessments we talk about, a multidisciplinary approach, medication management, alternative therapies. It really is much more geared towards effective measures of intervention, acupuncture, blocks, those types of things. I also don't think we've made it a priority in terms of education of clinicians. I don't think we've made it a priority programmatically in our hospitals. It's hard to make the business case for pain management. All those things really work against the clinicians and their desire to do more for patients.
Along those lines, there was a study, separate study by Johns Hopkins School of Medicine that found that medical school curriculum addressing pain is limited and often fragmented. And it really talked about the need to just update and freshen that. Do you see in the medical schools locally a commitment toward pain management, or is that something that needs to be done in the training locally as well?
Well, do I have to implicate our own medical school?
You don't have to.
And frankly, pain curriculum is quite brief. Most docs will say that they get 5 hours or less of training in the very thing that brings most people to the doctor. And so we have tried, and we have pain training programs, we have residents and fellows who train in pain, but at the essential curricular level, it's an under-taught subject.
You made a comment earlier about learning pain. Pain can be learned. The chronic pain is in the centers of the brain. Can it then be unlearned? Can your brain somehow help you to manage this pain, and do you counsel your patients like that?
Absolutely. I mean, the notion is that anything that can be learned can be unlearned. Any set of neuronal connections can be rewired in the same way that a patient who's had a stroke can learn to retrain a limb using a different area of the brain. We can do the same thing with pain, but what it takes is a recognition both on the part of the doc and the patient that in fact the paradigm has shifted, and we need not so much to focus anymore on the apparent source of the pain, like in the periphery or in my leg or in my back, and more on those centers of the brain that are lighting up, the emotional centers, the activation of sensory areas that truly can be retrained, and largely through addressing function, as Dr. Hayak talked about.
And Dr. Hayak, you're a pain management specialist, so how does your approach meld with that idea, the idea of sort of retraining the brain as one of the arrows in your quiver? How do you address pain?
So like we said, not all pain is the same. So the first thing that as a clinician you want to do is diagnose the type of pain that the patient is suffering from. And the type of pain could be, like you said, is it acute, meaning an acute injury that hopefully will resolve in a few days, or is it a chronic condition? And then if it's a chronic condition, which is really what the Institute of Medicine talked about, and really the big burden as far as expense, it's really much more expensive than surgeries, it's more expensive than heart disease and cancer and diabetes combined. If it's chronic pain, then you want to identify what type of chronic pain are we dealing with. Are we dealing with a cancer-related end-of-life type of pain, or are we dealing with a chronic non-cancer pain condition? And within these, then you can divide it further into whether it is what is referred to as nociceptive or in general inflammatory pain, like you would see in an arthritis condition, or...
That's okay, you're a doctor.
Or is it a neuropathic painful condition, as in nerve injury-related pain? And so once you make the proper diagnosis, there's a host of treatments. I wish it was just as easy as saying, okay, you have pain, take this pill, and you're going to be doing well. And so it's
not
really,
that easy.
It is not.
The approach to acute pain is, it seems like all hands on deck to start. You stop that pain quickly. Treat it quickly. Whereas chronic pain, low and slow, a little bit at a time, and gradually test that. Is that a fair assessment of how you might approach the strategy?
Well, with the definition of chronic pain, essentially that you've lived with it for a while, and that while is defined differently by different people. Some people say 3 months or 6 months or longer, and some people say longer than the expected time for normal healing. But whatever the definition is, chronic pain means something that you're living with. So if you're treating somebody with medication or an intervention, it's more prudent to go slowly. But like you said, if somebody's having an operation and they're going to have pain, it's going to be there for 3 days, you might as well go all out and even preempt or place the catheter or give the medication before the incision is made so that you can control the pain better.
There are barriers to treating acute pain in the hospital setting. And a lot of that stems back to the education that we have had in the past and how that knowledge, some of that is old. The concern that you have, and particularly physicians validly do, of respiratory depression after a surgery, the patient's inability to participate in their recovery. So we under-medicate patients for acute pain, I believe, and that's where we really need to get better.
And there are patients with chronic pain that believe they're under-medicated. And that brings us into the discussion about narcotics and opioid prescriptions, those types of things. We were talking during the lunch a little bit earlier, Dr. Hayak, you're not a big fan of those for chronic pain.
Well, it depends what chronic pain, again. So unfortunately, there's no one-size-fits-all in this situation. If somebody has end-of-life cancer-related pain, and we have in the audience is Dr. Wellman, who's a specialist in palliative care. Narcotics are a blessing, and I'm all for opioids for acute pain. So if somebody has an operation, of course it's going to be helpful for them. If somebody has end-of-life cancer-related pain, and of course, by all means, it's helpful. In chronic non-cancer pain, the data is poor as far as opioids, and the longest studies have gone, there's 3 studies that have gone for 6 months or longer, and these were usually sponsored by the drug companies that came up with an opioid. And so really we don't have long-term efficacy. If you are in your 30s and have chronic back condition and you're expected, based on mean survival nowadays, to live another 50 years, it is not fair to put you for 50 years on chronic narcotics. There are much more harm and bad side effects that can occur to you than if we tried some alternative measures. And there's no evidence, on the other hand, that they will be helpful for you over the long term.
Dr. Janata, you're nodding your head. You agree?
I do, and I think that another aspect here that we can add is that with chronic pain, there's often concomitant depression. 70% or more of people in chronic pain have depression. And one of the things that most commonly goes hand in hand with their receiving a prescription for an opiate at a doctor's office is the intensity with which they express their pain and the affective intensity that they have. that really may be an indication more of depression than pain. And so the problem is we have to be so careful that if we're going to use an opiate, which is in essence a central nervous system depressant, and the problem that we're really treating is depression expressed as pain, now we've created more of a problem than we've solved and violated the do no harm requirement that physicians have.
And is that a bigger consideration than the fear that some have about abuse of the narcotic medicine? The idea that somebody's either gaming the system in order to get it, or the fear, and some studies say it's a very low percentage, that people would become addicted because they were prescribed the medicine. Does that come a little bit lower in the ladder of concern than what you just described?
No, I would say that the concern about addiction is paramount. It's actually the number one reason for physician loss of license. And so most of the docs who are treating chronic pain with opiates have as a very high priority and concern the possibility that they're inadvertently contributing to someone who's abusing or addicted to or diverting that narcotic.
But the argument that's made by folks that are in pain is that the studies would show a very low percentage of people become addicted because they were prescribed that medicine, and that they're being underprescribed and not really reaching the pain that it could reach if doctors were able to be more free in those prescriptions. Dr. Hayak?
Well, there are no restrictions on physicians' prescription of opioid narcotic
Well,
medications.
fear is a restriction. Fear of somebody abusing the medication, fear of some sort of law enforcement action.
Right. Like we said, Mike, there's really no evidence for long-term effectiveness. So, the first obligation of physicians is first do no harm, regardless of fears. And so if you really want to avoid doing harms, you want to be judicious with the use of these medications. Before the mid-90s, opioid medications were used mostly for end-of-life situations. And concomitant with the introduction of new narcotics that were made, opioid narcotics made long-acting, some experts started talking about perhaps we should use them for chronic non-cancer pain, and pretty soon their use got liberalized. But if you look at opioid sales and you look at opioid-related death, you will see they are parallel. We have over 40 people dying every day in this country from opioid prescription overdose. And these are not always the patients. It could be the grandchild who raided grandma's cabinet. It could be somebody else, and sometimes it's the patient. And sometimes the patients themselves inadvertently take other medications that, with the opioids, can cause respiratory depression. These are dangerous medications that can potentially kill. It's not always the abuse, it's misuse sometimes that results in fatalities. In the state of Ohio here, since 2007, opioid narcotic prescriptions are responsible for more death than car accidents and suicide.
One of the things that blew me away in our conversation, Dr. Janata, the other day on the Sound of Ideas, a couple of callers called in and they said they didn't want to take opioids, or they had their own chronic pain problems, and they were able to overcome them by getting out of the house and taking a walk. Yeah. The idea that they went and got some exercise and did some lifestyle changes, and really it resulted in some attitudinal changes. What about the importance of that? When we talk about taking ownership of your pain and of your own management of your pain, what do you counsel in terms of people getting out and becoming more active?
Salim and I have worked together for a number of years, and we always work, I believe, to pair the relief that may be provided by a medication or an intervention with a requirement that people who are suffering with pain become more active on their own behalf, engage in exercise, in rehabilitation, in self-management strategies of all kinds. And I would always say that it's a requirement of an approach that uses an intervention or an opiate medication, that there be a pairing with physical therapy and occupational therapy and other kinds of rehabilitative strategies. Because actually the cure, the correction of the pain probably is going to come more from reactivation and gradual increase in function. That's going to help to break that pain cycle eventually if it's going to be broken.
So if you were able to re-envision the way chronic pain is cared for, Would that be the a main component of it? What would be your plan?
My plan?
Yeah, if you were to say, here's how we treat it.
If I was king,
You're in control.
I would always say that I think it's entirely appropriate under the right circumstances to use medications that are powerful, but there has to be a patient obligation on the other side to meet us halfway. They have to engage in the kinds of strategies that really are going to long-term be helpful for them. Whether that's meditation or relaxation or exercise or rehabilitative strategies of one kind or another. I would, if I were king, make it a requirement that to have access to the opiate medication, you also have to demonstrate that you're using it to enhance your function, not just to relieve your subjective sense of pain.
So it be written, so it be done.
Thank you. Thank you.
Catherine, what about Dr. Janata talked about meeting halfway in terms of what you do physically, but what about meeting halfway in terms of your expectations? When you have pain, should the expectation be that you don't have pain at all anymore, or is there a different scale of expectation for people who are in pain? Should they expect to have some?
I think it's really important to talk about expectations, particularly when you're coming into the hospital, you're going to have surgery, you have a particular illness, that there's the need to really sit down and mutually talk about what the expectations can be. Is it realistic post-surgery that you will have no pain? That is not realistic, but what is realistic? What's the goal that we're trying to reach? I think that all of these things that we're talking about now are really grounded in the relationship of connecting with the patient and the family, by the doctor, by the nurse, by the therapist, so that that individual really feels like you're making an effort to understand where they're coming from and what their questions are, what their issues are, to have empathy for them in their suffering and really advocate, but work with them. And this should be in the inpatient side as well as ambulatory.
You're describing compassion.
Yes.
And that's an important role in this process. Who is the bearer of compassion? Is it the nurse, or is it these guys, the doctors?
You know, I think it's everyone. And I think it's physicians, I think it's nurses, I think it's family, and I think it's friends. You know, compassion is having empathy for one's suffering and really working to alleviate it. And the first thing you can do that I think is so important is don't leave this person alone in their pain. And I don't mean that just physically. There are so many people that have pain that they're not believed. And that is a horrible place to be in. So it's really moving away from, they don't present the common kind of behavioral reactions of pain. It's just really understanding them and how they express their pain, what makes it worse, what makes it better, and the whole experience of how it affects their entire life, the fatigue, the inability to do things like they used to, fear of moving a certain way, you know, what really alleviates it. I mean, I think compassion is so important for all patients, but in this disease, to be alone with it is tragic.
And yet there is that rub some dirt in it attitude. You know, get up and just basically shake it off. On Cleveland.com the other day, after the Plain Dealer ran a story about pain and pain management, one of the commenters said, "We've become a nation of pansies," and went on further to talk about how folks basically just have to stand up and quit whining. And I wonder if that's an attitude that, when you talk about having compassion, it needs to cut through, which is there is a very thick callus of folks that are like, you need to get over it.
It absolutely does. And you'll hear this in certain specialties. You know, this is like the obstetrician telling you that labor doesn't hurt because they've never had a baby before. I mean, you have to get past all that. I'm talking about the male obstetrician. Sorry.
That's more likely, you're right.
Yes.
Somewhat more.
I think we have to call each other on that. That's not an attitude to have towards someone who's suffering.
And do any of your fellow doctors have that kind of attitude? Do you have to sort of let them know, and it goes back to the education component in medical school, but beyond, Do you talk to them and say, no, pain is real, even though you, the doctor, can't see it on an MRI? Dr. Hayak?
Well, for our physicians in training, they are rated on also their compassion on how they deal with the patients. But you are correct, Mike. Pain is what the patient says it is. So if the patient says in pain, then they are in pain. However, sometimes, we have some objective tests to do and to ensure that somebody is not malingering because they want to get out of a court date and claiming they are in pain and they want to stay in the hospital or something.
Or collect workers' comp or a variety of other.
Sometimes we may be able to do, but there are very rare instances of malingering, but most of the time patients are in true pain.
It's interesting that, malingering, so many of our systems are set up as though malingering is way more common than it is. In the studies in malingering, it's actually quite rare, even in Bureau of Workers' Compensation patient populations and others where we'd expect that people may be sort of bellying up to the public trough. And in fact, the rate of malingering is quite low.
Fascinating conversation today at the City Club of Cleveland. We are listening to a special program featuring a panel discussion with local experts on pain diagnosis and treatment from University Hospital and Case Western Reserve University. We will return momentarily for our traditional City Club questions. We encourage you to formulate questions for our speakers and our panel. Now I'm going to remind you that your questions should be brief and to the point. We welcome all of you here, especially those who are guests. We hope you will join the City Club and become active in our ongoing civic dialogue. This year, the City Club of Cleveland turns 100 years old. There are a number of events planned. To learn more about the 100th anniversary events, visit the City Club website. That's at www.cityclub.org/100. We welcome all of you here and those listening to WCPN 90.3 FM, WCLV, WTAM, or one of the many radio stations across the country. Our television broadcast partner is WVIZ PBS Idea Stream. Television broadcasts of the City Club are made possible by Cleveland State University and PNC. Our live webcast is supported by the University of Akron. Friday, January 27th, the City Club welcomes Karen Mills, Administrator of the Small Business Administration. Next Tuesday, January 31st, the City Club hosts a panel discussion on exotic animal legislation in Ohio as a result of the tragedy in Zanesville in the fall. If you wish to make reservations or order a CD or DVD of today's program, please call 1-888-223-6786 or 216-621-0082. We are pleased to welcome guests at tables hosted by IdeaStream and University Hospitals. Thank you for your support. Now, we would like to return to our panel for our traditional City Club question and answer period. We welcome questions from everyone, including guests. Holding the microphone today is City Club Program Director Carrie Miller. Now, for our first question, please.
And if you don't ask a question, I will point at you randomly and make you ask one.
Thank you so much. I want to thank the panelists, especially Dr. Hayak. In the interest of full disclosure, I have done work with the City Club. I'm a fundraising consultant, and I'm a patient of Dr. Hayak who has complex regional pain syndrome. So I have three questions for the panel or Dr. Hayak specifically. The first issue that I'd love to have more amplification on is when you say the whole goal of the treatment is to restore function. Like, I can't even count the number of things I've quit doing, but I kind of don't think about that. So that's function, and definition of that is one question. The second, and I don't know if anybody else here knows what complex regional pain syndrome is, but it's not fun. There's a disparity between the injury that kicks off complex regional pain syndrome and the severity of the pain. And if you can talk about that disparity, I think it would be of interest, certainly to me and hopefully to others here. And the third question is, are you in touch or are you aware of the fact that in yesterday's Chemical and Engineering News, there was an article by, there's research going on at WashU in St. Louis, fighting neuropathic pain, which I have a copy for you.
Okay. All right, we'll start with the first two. There's only three, though? Only three questions? Dr. Hayak, your patient, your answer to start. Can you define the restoration of function? What do you mean by that? And again, is it expectations driven?
Yeah. For Susan, complex regional pain syndrome, and I'll address actually both questions with the answer, is by its definition is pain disproportionate to the injury. So patients would have had what may be, in some cases, a trivial injury. In other cases, it's a much bigger or crushing injury. But the pain persists beyond the duration of the injury or accident or surgery and is disproportionate sometimes to the original injury. And it mostly affects function. And functional restoration is the mainstay of the treatment of this condition. Unfortunately, as patients are trying to restore function, usually it affects a limb or more than one limb, they are met with a lot of pain, which hinders progress. And so that's when they come to physicians like myself to help control the pain so that they can resume daily activities and restore function through rehabilitation.
That was the question, though, is what exactly is function? If function before was running a marathon, and function now is walking up to the corner to get a quart of milk, is that function? Or should I get back to the point where I can run the marathon and function isn't restored until I get to that very original fact?
Well, different people have different goals, but and depending on the extent of the injury, running a marathon may not be a realistic function, but you may have to set realistic functions that are, reasonable for normal human beings, including yourself and the physician, so you can come to an understanding of what would be an acceptable function. And Jeff and I, a lot of times before doing implants or procedures on patients, we ask them what are their set functions, what do they want to be able to do and accomplish before we go ahead and do that.
And one of the things, again, just to bring this back on the table, is that when people in chronic pain talk about their distress, they talk about not only the pain itself, but they talk about the consequences in their lives. So that the distress is not just pain, but it is also the suffering that accompanies pain. And we think about the function and restoration of function essentially as being restoring those kinds of activities that bring us a sense of meaning, that bring us pleasure, that bring us companionship, that bring us relationships, that bring us income. And so a lot of that effort is in not just relieving the pain, but relieving this complex of consequences that can evolve out of chronic pain.
And are we familiar with the study that was referenced there? We'll get on that. We'll have that information. In fact, there's a copy waiting for you as soon as this is over. Next question, please.
I have a quick question, and this was addressed a little bit earlier in the week in some of the other reporting. It's this question of fibromyalgia, of this just sort of general malaise, I guess, and maybe I'm being as stereotypical as some people are in the way I describe it. But can you talk a little bit about that and the diagnosis and the treatment of something like that that, again, is as invisible as other types of pain?
Dr. Janata? Certainly. Fibromyalgia is a syndromal condition. It is a collection of symptoms. And there's been a lot of debate, frankly, in medicine about fibromyalgia, what exactly it is. And yet the people who struggle with fibromyalgia pain will talk with exquisite precision about the nature of their pain and how very debilitating it is, and how one of the most debilitating aspects of it really is the fact that they're so often disbelieved by virtue of the fact that there are not physical findings. But we know that fibromyalgia is highly associated with chronic sleep disorder, with mood disorders, and with absent exercise, with low levels of activity. And so a lot of the treatment, in addition to the pharmacologic treatment that's increasingly available, aims to address those other issues as well, to address coexisting mood disorder, to improve quality of sleep, and to get people back exercising into a pool or at a gym.
Dr. Hayak, do you see a lot of patients who complain of fibromyalgia?
Yeah, fibromyalgia can affect, unfortunately, up to 5% of women. It's 90% of the patients with fibromyalgia are female. And it's associated, like Jeff said, with a lot of fatigue and functional symptoms. And the patients are quite distraught with it. But what I tell them is typically the main treatment for it is do opposite of what it makes you feel. If you feel like sitting at home and laying in bed all day, do the opposite of that. Really, the main treatment that has been shown to be effective is aerobic exercise that's done at least 5 or 6 times weekly, on a weekly basis, 5 or 6 days a week. So I encourage the patients to involve in low-impact aerobic exercise. And then there are some newly FDA-approved medications. We have 3 FDA-approved medications, but these by no means resolve the condition. People typically get better if they exercise and sometimes take some of those medications.
Do the opposite of what's causing the pain. It sounds exactly like that punchline, doctor, it hurts when I go like this. Well, don't go like that. It sounds almost exactly like that, like it really is true.
Essentially, don't sit at home and relax, because really that's exactly what it makes you feel like doing, and then if you disuse your muscles, they will ache more. It's fibromyalgia is achy muscle and or joint insertions, and the more you do what the condition makes you feel like doing, essentially lay in bed and do nothing, the worse you will be.
And Catherine, you talked about compassion with people, but sometimes, especially in a case like this where you're saying you need to get up and move, and you don't feel like moving because the condition you have makes you not feel like it, but you'll feel worse if you don't. What about that motivational aspect? There's compassion, but there's also sort of that kick in the pants. Is that part of what the role is from your end?
Well, I think it's the approach you use towards it. I don't think you can ever force anybody into anything. I think it's really talking through what their fear would be about doing that, take it in small steps at a time, then be there to support them. I think that all of it is in the way and the manner in which you relate to the patient.
Sometimes having a buddy or a spouse that's supportive is very, very helpful.
Mm-hmm.
Our next question, please.
I'm struck by what each of you have said about how many people who go into nursing, go into medicine, maybe haven't had the kind of preparation that they need to really do well in caring for people with pain. What might you say to the people listening to this program who maybe have chronic pain, have seen someone, and they don't really feel that connection with the provider, or don't feel like they're getting the kind of care that you've described here? What might you say to them that they could do to help the provider give them the kind of support that they need in their ongoing journey?
What an interesting question. What can they do to help the provider? I think, let's get back to where this starts. If this starts with inadequate education, then in our medical schools, nursing schools, and so forth, I think that that we have to find ways to help physicians embrace seeing patients who have chronic pain. And there's a large number who frankly do not in the community, in large part because they don't have the training, they don't have the experience, they don't have the sorts of expertise that Dr. Hayak's developing in his fellows. And so, first I would say that is trainable, and that physicians who have been trained in the community find that chronic pain is really quite satisfying to treat if they have the right tools, if they have the right knowledge, they've been exposed to the right curriculum. And the patients that they treat can do quite well. So your patient probably needs either to find one of those trained physicians, or those who don't think about treating chronic pain kind of as though it's a poke in the eye, and instead embraces it. And those physicians are out there, and and increasingly they're out there, I think, as our training works to get better at the medical school level.
Dr. Hayak?
So just to echo Jeff, the modern concept of chronic pain management is multidisciplinary or interdisciplinary, and Jeff and I had some of those clinics where we would see the patients together and sometimes with another specialist who was a neurologist, and give our varied input into it. Now, sometimes that is difficult to do in a single solo practitioner, sometimes out in the country, but increasingly it is recognized that if you want to put a banner and say you're a pain clinic, you would have to have interdisciplinary. Now, that brings up the issue of cost and availability, but if a patient has chronic pain, they should know that their condition requires interdisciplinary treatment. And sometimes if they're dissatisfied with the way they are being treated, sort of it's a poke in the eye, that perhaps they should seek a more comprehensive center for their management.
And we're not talking about a small number of people who are dissatisfied. 116 million people in this country experience chronic pain. 50 million of them say they're disabled by that pain in some way. And half of those who were polled in a recent study said they don't get adequate relief. This is a widespread problem that people are perceiving. The answer for all of them is to find the right provider, or is it for the provider to find the right strategy?
I think it's both. You know, I could speak about the inpatient hospital side, is that there will be many patients in terms of the responsiveness to their need by their physicians is not meeting their need. And I think that is due to a lack of education. And nursing plays a role there of supporting the patient in that and letting the patient talk about that and advocating for the patient. We have many experts. I think what physicians and nurses need to learn is that whatever you're doing, if it's not working, seek out other resources. There are experts that can come for consultation. There are so many adjunct therapies, alternative therapies, whether it's in the area of rehab, whether it's relaxation, whether it's music therapy. There's just so much out there, but we tend not to use it.
And use the multimodal approach,
yes.
Right, Dr. Hayak?
Correct. The answer to your question is perhaps, you know, the way the question was posed to these chronic pain patients was not adequate, because the way we think of pain, most of us think of pain like acute pain. When you think of chronic pain, like Kathy said at the beginning, it's a disease. And so if you were to poll patients who have diabetes, the poll may have been posed, the question may have been posed differently. You would have not said, how many of you have cured your diabetes? How many of you have the diabetes better managed? Now, sometimes some patients may have their sugar levels high, but they know it may be because they ate a lot of cookies the day before, or they were not compliant with their diet. And same thing with pain management. I mean, your physicians can be doing the best to treat your pain, but you also have to do your exercises, and you have to strengthen your core or whatever the condition is. So chronic pain is a disease, and so we never call ourselves pain cure clinics. We're pain management clinics, and we manage the pain just like diabetes is managed. And sometimes we're successful, sometimes we're not successful, but it's also a partnership with the patient.
Next question, please.
Yeah. Thank you very much for being here today. I suffer from neuropathy from a 5-year-old injury, a broken back. And I'd like to make just one recommendation, is that anytime they're at all possible, when you have a panel of people having these discussions, you may want to check into having at least one person on that panel who has suffered from chronic pain of one degree or another and has been through A to Z. The young lady's question I thought was excellent. And in my experience with my recovery, I was very fortunate to find a primary care physician who had to pay her bills and really couldn't afford to give me the kind of care that I needed, the compassion, because the reimbursements were there. She was kind enough to set up our appointment at the end of the day, and many times took an hour and a half to do that because she was both compassionate and caring. My question is, there are no disciplines. This afternoon I'm going to be meeting with a friend of mine who has just come to some pain from a disc. And he is more frustrated about not knowing what his options are and in being in control of that, because he's got all these separate disciplines. If you start with a solution to a problem, and the solution is there's no primary advocate with all the disciplines, you're running from doctor to doctor to doctor to doctor, and 5 years later you haven't solved your problem. Do we see that at some point in time we're going to have a pain management advocate who encompasses all those disciplines and knows all those solutions that are out there and helps direct that patient?
You bring up a lot of excellent points. The question of triaging patients with chronic pain is a very important question, you know, because if you have abdominal pain, you may go to a gastroenterologist, And if you have foot pain, you may go to a podiatrist. And if you have a headache, you may go to a neurologist. And if you have all of them, you may have seen all the patients at the same time. And actually, a lot of patients with fibromyalgia, the question was brought back, they suffer from abdominal pain. Sometimes neuropathy is concomitant with it, and migraine is concomitant. But if the patient goes to one specialist at a time, no one is seeing the big picture. It's like being too close to the elephant to appreciate it was an elephant. And so this is a very important question. The most important thing to figure out when seeking care is, has your pain been a chronic problem? If it's been a chronic problem, you may, based on your primary care physician recommendation, start out by seeing a chronic pain specialist, and then from there, if there is something that has not been worked up, be triaged. But you're right, a lot of patients, for example, fibromyalgia, it takes on average 5 years to diagnose a patient with fibromyalgia because the patient goes from specialist to specialist to specialist, and no one has seen the chronic picture, and they end up having a diagnosis delayed by about 4.5 to 5 years before, on average, before it's made.
What about the suggestion? Do we already have pain doctors, just a pain advocate, or should that be part of the healthcare system, as was suggested by the questioner?
What the model you're suggesting is in place for other chronic illness programs. Cancer, for example, has nurse coordinators that follow the patient because there's multiple specialists, and they try to coordinate that. So I think it's an excellent idea. I think the issue is it's not recognized. Pain isn't being recognized as a chronic illness, and it's not being reimbursed in the optimal model for care for patients.
Well, and I would come back to the idea that internal medicine and family medicine both as we get better at training them and as they get better at coming to an understanding about chronic pain and how it works, should be playing that role. That they should have a central role in coordinating the specialist care that you may then seek out as well, not only in terms of providing compassion, as your physician did, but also in terms of knowing where and when to direct you to create a de facto interdisciplinary team, even in the community.
And to your point about the panel, I think you bring up an excellent point. The benefit of having an event like this at the City Club with this kind of an audience is we almost always get all that representation, as you saw here with yourself, with our earlier questioner, and we do count on that. And thank you very much for sharing your question and your comments as well. Next question, please.
Yeah, you know, I'm struck listening today about the difference in expectations when it comes to patients and the treatment of pain. The vast majority of people who suffer from chronic pain first suffered from acute pain. And it strikes me that the way doctors and the medical profession treat acute pain doesn't really require the patient to take an active role in that management. Sit back, take an aspirin, take a drug, 3 weeks it's gone, the inflammation's down, I'm back at work. And so we're trained at a fairly early age that I feel pain, I'm going to the doctor, oh, I don't have to do anything but basically sit back. And then I get prescribed a pill or something. And then suddenly something happens, we begin to suffer from chronic pain, and now that relationship is completely different. The role of the patient is completely different. Can you talk a little bit about what sounds to me like the significant differences between being a patient and being treated for acute pain and being a patient and being treated for chronic pain?
Again, a great question. I think that what you're describing is that the burden begins to shift. In the case of acute pain, the burden is pretty exclusively on the providers to give us the medications that help us to get through this painful recovery period, and then things just take their course and pain gets better. And it requires a paradigm shift. It's a paradigm shift that patients have to make and requires some real education about the importance of not following their instincts. That the instinct around pain is to guard and to restrict activity and to wait till it's better. And so part of what the providers need to do is be very good at saying, look, I know you feel as though when you start walking again, you're doing yourself harm because your body's experiencing pain. You need to distrust that instinct. You need to distrust those signals and your response to them, and know that in the pursuit of getting more active again, and that you will experience more pain, and that that's normal, and that that's what we expect, and that it's like going to the gym for the first time if you haven't been there for 5 years. It's going to hurt. We expect it to hurt more. And what we need you to do is understand that that's part and parcel of the process of working to correct this chronic pain process. And that communication is that communication between physician and patient is a central shift in the way we go about treating chronic pain.
Very short amount of time left in our program. Would either of you two like to weigh in on that as well?
Well, I'd just like to add that I think even in the acute pain, that patients should be very involved in the plan of care and how they manage that. And that it's not always just the professionals dictating what that should be.
And the issue of whether acute pain progresses to chronic pain does not always have to do with how well was acute pain treated. Often the cause for chronic pain is unfortunately a nerve damage or nerve injury, and so I think a lot of those people who end up having chronic pain after an acute injury may have had a nerve damage or persistent inflammation, which most of the time would get corrected afterwards, but usually it's nerve damage problem. And but then also you get the amplification that Jeff talked about and the plasticity in the central nervous system, which makes it worse. But in general, it is not that we poorly managed acute pain, and that's why we ended up with chronic pain.
Thank you, Dr. Salim Hayak, for your expertise today, and Dr. Jeffery Janata as well, and Catherine Koppelman, RN. I've really appreciated our conversation. And now let me turn it back over to my colleague, Mark Rosenberger.
Thank you. Today at the City Club, we have been listening to a panel discussion featuring Dr. Jeffery Janata, Associate Professor for the Department of Psychiatry and Director of the Behavioral Medicine Program at the Case Western Reserve University School of Medicine and University Hospitals, Dr. Salim Hayak, Associate Professor for the Department of Anesthesiology at the Case Western Reserve School of Medicine and Chief of University Hospitals Division of Pain Medicine, and Dr. Catherine Koppelman, Clinical Assistant Professor at the Case Western Reserve University, Francis Payne Bolton School of Nursing, and Chief Nursing Officer at University Hospitals. Thank you, panelists, and thank you, ladies and gentlemen. This program is now adjourned.